So I wanted to dive in and just kind of focus on some of the questions that I shared with you regarding the Vivitrol service at Streus Pharmacy. So, um, when you guys were making the decision to offer the injectable naltrexone service in the community, you know, did you engage in any kind of formal needs assessment, such as getting input from community stakeholders or even conducting an initial market assessment?
Well, I wouldn't call it very formal. What had happened originally is our resident at the time had brought back from mid-year a presentation that was given by the resident from the University of Kentucky who has initiated a similar program. And our owner, Jeff Kirchner, had approached me and said, maybe you want to look into this and see if there's anything that we could do. And the needs in our community were relatively inherent. We did have and still do have a existing relationship with the county's health department, and a fair number of our patients already, amongst other things that were being treated, had issues with substance abuse, and questions had kind of been existing in advance about better ways to take care of all of our patients. So between stuff we already knew about pressures to stay in business with an older model that was just about volume of scripts and reimbursements, with all of that shrinking and competition being high, we had pressure to diversify our services to begin with, and ownership was very interested in remaining on the cutting edge as an independent pharmacy, to be the first to get into offering different services or explore different areas of pharmacy where we could be of benefit.
Just to dive a little deeper, you mentioned that you kind of had a pre-existing relationship with the county health department, and you were aware of the need in the community. So, you know, what steps did you kind of take to kind of have that that pulse on the community, for the lack of a better word, to kind of
Mhm.
really build that relationship with the county health department and really kind of have a sense of, yeah, these are the needs that are in our community?
Well, sure. So we had two, well, one was a serendipitous encounter, I would say, with a nurse practitioner group that had approached us as a location for injections for a lot of their patients who were on long-acting antipsychotic injections as well as Vivitrol. And they didn't have any representation up in the Green Bay area. So they were looking for an independent pharmacy to work with. And we were able to benefit from a lot of the existing relationships that they have already built with some of the providers, though most of them weren't specifically in our area. And we also had a relatively active sales representative from Alkermes, the manufacturer of the drug Vivitrol. And they had been doing detailing with a lot of the providers in our area for a long time. And that gave us that initial impetus that we had. From there on out, it was more about discussions at the executive level, where we wanted to make sure that if we were going to delve into this program, we did so knowing that there wasn't an existing reimbursement structure for any of the service, and there still isn't really. And what we would have to do would be to really establish the value of what the service would mean to the community coming from the pharmacy, and be willing to encumber the costs that were associated with that. So the next steps of being in communication with our county health department were to speak with the nurse practitioners and doctors over there, and they had made it relatively clear to us that they weren't interested in administering this injection out of their site. And some of that had to do with education, and some of it had to do with, well, I guess parts unknown about the actual extent of need in their particular patient population. We did also know that from the existing state, I guess you might say, of affairs with the opioid court, or from a rehabilitation center that was in town, that options were limited to folks. So we had a place to start. We had a number of patients that were being pushed to us by the nurse practitioner group, and some leads on a few others here. So between that and an existing desire for us to just jump into this and see what we could make happen, that's where I would say we would have, we found our initial areas of assessing what need we had in our community. And, honestly, it was already a kind of a broad established need to begin with the governor's task force, as well as, mainly a nationwide awareness, I would think, of the opioid crisis.
Let me just ask, why did Streus Pharmacy ultimately make the decision to offer this injectable naltrexone service in the community?
Our CEO and owner of the pharmacy had been president of PSW and has been very active in that organization, where the advancement of the profession and lobbying for our profession has been very, very strong, even comparatively to how that may work in other states. So that gave a lot of impetus for our executive team to decide that we would jump into this without having that full, say, spreadsheet completed. There's been a long history at our pharmacy where that willingness to take on a little more risk or to jump into something where the profit and loss statement is not going to show a financial benefit of doing this, but rather taking a long view, where it'd be worth giving this a shot, because it would be a chance to establish relationships with providers and be ahead of the game when times would come, should pharmacy really shift more to being that access point for receiving services such as long-acting injections like naltrexone.
So how long have you guys been offering this service at Streus Pharmacy, and roughly how many injections do you do a month?
Well, when we started, it was December of 2016, and I do believe I gave my first injection in January of 2017. That first year or so, the number was limited. We had some issues when it came to getting the word out, that we were doing this. There was a lot of lack of understanding what this whole process really required and what we actually offered. But there was a little bit of a slow build on the front end. And once word had gotten out, we do have a number of people that we work with now in the community, and a lot of different providers and health organizations that referred patients to us. So I would say now, just total with our long-acting injections, we're probably doing, overall, maybe it fluctuates because there is recidivism when it comes to this patient population, particularly when it comes to opioid use. I would say on average, probably about 24 injections on a monthly basis.
So when you guys implemented the service there at Streus Pharmacy, what impact did it have on kind of the existing workflow in the pharmacy?
Well, that's where we needed to be flexible and nimble. It had a substantial impact on us, even though we have a large long-term care pharmacy, therefore a fairly large number of pharmacists on staff, so that we had the flexibility to cover that pulling out of workflow for some of our technicians and me in particular. I think on the front end, I really wanted to see this go, so I was giving a lot more of my time away, so that we could accommodate patients and get some momentum here. And the impact, I think, was underestimated in the sense that an initial appointment takes a lot more time than we had anticipated. Between patient education, doing initial urine drug screen, Vivitrol itself is something that the preparation of the product alone takes several minutes. That we didn't necessarily appreciate that on the front end as we were stumbling through this, that we were spending about 45 minutes on an initial appointment and 25, 30 minutes on a follow-up. Of course, once that got streamlined, now it is something where we typically need about 15 minutes to give an injection, maybe 10 more for one of our initial injections to a patient. The workflow had some other impacts, and we weren't necessarily anticipating how to accommodate for the follow-up that would have to, of course, occur to maintain patients in the program. We didn't have a great workflow setup, and that was something we had to learn somewhat the hard way going forward when it came to patients who were no-shows, or we needed to reschedule an appointment, and we had previously arranged for, okay, this is the day we'll have qualified pharmacists to inject. And on the front end, we also had to do training to get people who are able to do this. In the early years, I was the only one that was willing and trained to give these injections, and that certainly took a lot more of my time, but we now have it set up with less of an impact, with a higher volume of trained professionals there to administer, but it still is one that we don't want to underestimate how long it actually takes, the actual cost of time that it requires for us to maintain this program.
So just a quick follow-up, John, when you talk about, say, like, you underestimated the time for, say, somebody no showing to an appointment. Can you just say a little bit more about, what you mean by that, and then what impact, what did you have to learn to do, to address those no-shows?
Sure. So we would need to follow up with the physician who had ordered the Vivitrol in the first place, and finding the time out of a regular workflow where you really don't have a minute to stop sometimes and think, to include this at the end of the day easily was something that got overlooked. And when you try to reach out to a patient, one of the things that takes longer is that a lot of the folks don't answer their phone, or have a non-working number, or some other kind of complication in getting to reach our patients. A couple of the things that also ended up taking more of our time was a delay in arrivals, as many of our patients who were on Vivitrol did not have a valid driver's license or access to their own transportation, and required rides or taking public transportation to come in, which threw off the appointment time. Maybe we had a 1 o'clock scheduled and they arrive at 1:18. Well, my philosophy on this is, when someone's ready to be treated, we're going to go ahead and make the accommodation to treat them. And I really don't want to send somebody away who we're treating for addiction and give them that, you're on your own for the next 24 hours, where one more day is just, one more day for one of our folks to be chasing dope. And I don't think we're going to have a success with the program if we take an approach of all the onus is on the patient to come to us. And so we put in that extra time to make it successful.
So what do you see as the benefits of offering the injectable naltrexone service in the community?
Well, I think there's a fair number of the benefits. One of them is from the patient's perspective. For a patient to go into their physician's office and receive this, they're going to have to adhere to a relatively strict schedule of when you arrive and when you do this. You're also going to have to pay money just to walk into the door at your physician's office. And without adequate insurance coverage, this could be something that just on its own is a deterrent for our patients. For other folks, it's a matter of a stigma, especially if you're relying on some other form of transportation. If you're going to, say, receive this at a rehabilitation clinic or somewhere where it's known that the folks who are going here for some kind of drug treatment, that creates a stigma. Whereas showing up at the pharmacy, everybody goes to the pharmacy for some reason. Nobody has to know why you're walking into the pharmacy or questions it, really. Creating additional points of access as well as how easy it is to arrange a time to access, is probably the biggest perspective, or I'm sorry, the biggest benefit to our patients, especially in the, in Green Bay. There's a lot of rural area around here, and
Mhm.
folks, to get to their provider who would be willing to do this, may have to drive more than an hour or more. It's nice to have something where you can just pop in your community and have shorter distances to go, fewer barriers in the number of miles that it takes or the time it takes to get scheduled for an appointment. We could accommodate someone quickly, and we could be very flexible with our times. We didn't have to schedule out several days or fit you in specifically at this time. We'd be able to work around a work schedule or a transportation schedule. So from the patient perspective, that really increases access. And the other area would be, say, from the needs of the providers. And one of the benefits is that there's, as we learned, a lack of understanding or education on how this whole process should work. One of the unique things I've experienced during this whole program getting underway at Streus is that the tables were turned in some ways, and that it was the physicians who would reach out to us directly and ask, how do we do this? How do we treat this patient? So it gave us an opportunity to provide benefit to all of the providers who would ask this question, or give us some insight anyway into how we needed to approach this detailing we would need to do with providers' offices to educate them about the service and get them to appreciate what it is that we offer clinically. So there's a benefit in that, and also just playing to the community, the opioid courts or the different recovery centers, everywhere that is affected by the opioid crisis, it gave an additional resource as well to help bring down some of the silos that exist between every stakeholder in treating a patient. A lot of times you have several players. You have the court system, you'll have some independent counseling or recovery centers, you'll have the doctor's office, you'll have us where we're receiving the injection, and communication between all these different entities is sketchy at best. It's very difficult to coordinate, especially in a timely fashion. And when it comes to treating addiction, time is of the essence many of these cases, and there simply isn't in a lot of our patients time to wait to hear back from Dr. So-and-so, or wait to hear back from the insurance company, or try to get communication between several parties at once. So a benefit for a chance to be a central hub for this, and communication and coordinating the care for our patients is one of the larger benefits. As we all know, that recovery is not something that is strictly going to be done by drug treatment itself. It's all part of a more holistic approach. That means we have to get in communication with these other areas.
So just to kind of flip it on the other side of the coin, John, you talked a lot about the benefits, and I think you alluded to a little bit earlier about some of the challenges, related to, getting the word out and making people sure that they understood the service that you're offering. But were there any other, or were there unexpected challenges that you encountered, and if so, how did you address those?
Certainly, yeah, there were some larger ones and some smaller ones that it took us time to learn about. One of them was the extent of time it takes to reach a provider when it's in the moment. We might have something as small of a hiccup as the provider failed to write that the injection is authorized to be given at the pharmacy. And I have a patient here right now ready to treat, and they need to catch their next bus home. And if you've ever called the physician's office to speak to the doctor, it's almost like you're trying to speak to the Don. You got to go through all the steps of the receptionist and the nurse, and then hopefully hear back and expect that your message was conveyed exactly as you intended it to, and not like a game of telephone. So that was one of the bigger challenges. And a lot of that goes back to the education too, as to how the whole program works and what we really need back from our providers' offices. From the patients' area, some unexpected challenges we had were one thing just came up the other day that I hadn't thought about, and that is when we do the initial drug test, it is for the benefit of the patient only. We want to make sure we are doing no harm by putting somebody into withdrawal, and that's why we do this. We're looking for opioids in the system, and that is it. I had a patient ask me, quietly as we're in the room, "Are you going to tell my doctor about this? Who else do you tell about all the results of this test?" The drug panel itself does test for amphetamines, cocaine, THC, benzos, and their concern was that someone was going to find out that one of those substances was in their system, and that was going to cost them their job or something like that. So educating a patient that, look, what you do is, really more of your choice. I can talk to you as a healthcare professional about it, but the only thing I'm interested in when it comes to this drug screen is making sure we're not doing harm to you. It's there or it isn't, and all I report back to the doctor is that it was clear we were okay for administering the Vivitrol. Another unexpected challenge we had is if you go to a doctor's appointment, you expect that you'll be sitting in the waiting room. And if you have a 3 o'clock appointment, you're probably not going to be put into the smaller individual room until 3:10, and it's going to take 7, 8 or more minutes to see the doctor. When we have patients coming in, it was amazing how many thought, I have appointments at 1 o'clock, it's 1:03. Why am I not being served? Having that difference in expectation of setting and how quickly it takes to be served was one challenge that we still have, in fact. And a third challenge that we didn't expect is people don't necessarily have an appreciation of the value of a dollar and what it costs in terms of, social costs, personal costs, the cost to go to recovery pales in comparison to a copay cost. One of the benefits is that we do have states and people who are covered by Forward Health Estate provided insurance is is anywhere from $0 to $3, and that caps out at that. So it's inexpensive, but I found that the patients we have who are most adherent were patients who had the highest copays that chose to receive the injection. As one person told me, when they were faced with a $350 copay for this, it's like, well, that's only half of what I was spending on alcohol or, whatever they would have been spending for the drugs they would be, getting. So I found that to be something that was an interesting challenge to get over, was that perception of what the value truly is.
Wow.
And so,
Go ahead.
sorry, I just was going to throw in about the insurance to having to require the drug to come from a specialty pharmacy that takes an extra day. And again, the challenge of one more day being another day to use, and that being a problem.
Yeah. Knowing what you know now, what would you have done differently when starting the service?
If I could go back and do it again, I think one of the things we would do is educate early and often in the eyes of our providers and all of the stakeholders, including the patients, to mainly those two groups, as to what the benefit is, how the process is going to work, and what we need from every party involved here. That seemed to increase our efficiency as well as an understanding that led to better adherence and provision of care to our patients in a timely manner. The other thing I think I would do differently is I would do more advocating. Another area we haven't really talked about necessarily was in terms of lobbying for payment for giving this service. And that's an ongoing battle that we're still involved in. But to engage sooner with that kind of legislative lobbying or others to coordinate a group that might convince insurers to ultimately pay us for providing a service where I make more money giving a flu shot, which I could probably give out of a moving car, than I get reimbursed for giving Vivitrol, which is $0, and it takes up a lot of my time and is more specialized skill. I think what I would want to do also would be to really train more folks on site to administer this injection. When you're a one-man show in a pharmacy, it's very, very difficult to break away from workflow. And to implement a program like this, it's going to take some creativity. As I had mentioned, I have more pharmacists on staff at Streus, but to get buy-in and to get training done for folks who, when they went to pharmacy school, the thought of my job being to give gluteal injections probably never came up. But you know, as in all industries, the expectations evolve, and pharmacies are probably one of the better examples of how what the job is has really evolved over time. A couple of other things I would do differently. I would create a piece of communication that laid out for our patients just what the expectations are going to be. The number of folks who I had come in that didn't expect that they had to give a urine drug screen, even though we had told whether it was through their doctor or however that it was going to be necessary, that the injection would be a gluteal injection. That was one little oversight that we had. One of the patients who had rolled up their sleeve as soon as I was preparing the injection, we're going to be administering 8 times the volume of your typical flu shot or your flu shot here. And to explain to somebody that that's going to be a gluteal injection, it caught this one person very much off guard, and to convince them that this is actually the best way to do it was something that I think would be a beneficial thing to have had up front. And lastly, coordinating this more holistic picture of care, bringing down those silos, is probably something I would have loved to do a lot more on the front end. I think would have had better rates of adherence on the front end if I was able to ensure right at that appointment that, okay, who is your AODA counselor? Do you have a recovery coach? The person who wrote this prescription, was this your regular doctor, or is this somebody who gave you one prescription one time only as you left the rehab facility or the correctional facility? And establishing proactively coordination of care going forward, as I've seemed to have seen a bimodal model in the pharmacy where I'll have someone come in for either 0 or 1 injection, and I never see them again, or I have somebody who sticks with the program and gets it, you know, say through 12 treatments or more. And very few people that show up, they'll get 4 injections and I never see them again.